Welcome to this special Gastro Girl podcast. This episode was produced in collaboration with the American College of Gastroenterology's Patient Care Committee. Here's your host, Jacqueline Gollin.
Hi, everyone. And today I'm welcoming back Dr. Nandi, Associate Professor of Clinical Medicine at Penn Presbyterian Medical Center at the University of Pennsylvania. He is the regular host of his own academic podcast, GI Insights, IBD Crosstalk, and he is a member of the American College of Gastroenterology's Patient Care Committee, and that has partnered with us to make these awesome educational podcasts. And we're going to discuss today all things celiac disease. If you've been recently diagnosed or know someone who has been recently diagnosed with celiac disease, or maybe you think you have the symptoms of celiac disease, listen up, because today we're going to cover everything from symptoms to diagnosis to treatment for celiac disease. Welcome back, Dr. Nandi. So good to see you.
Thanks for having me in that great intro again. I appreciate it.
Oh, you are so welcome. So I don't know about you, but I think it's really alarming that there are probably an estimated up to 83% of Americans who have celiac disease that are currently undiagnosed or misdiagnosed with other conditions. And I was just looking at the Beyond Celiac site, and they have all these great statistics. And it estimated 1 in 133 Americans, or about 1% of the US population, has celiac disease. And these numbers could be even higher globally. If you can, is there anything to add about this? I thought it was pretty alarming.
It is alarming, it absolutely is. And, studies show that over the last few decades, there's an increasing prevalence of celiac too. So it used to be, when I was in medical school, they used to call this a rare disease. It's not a rare disease, right? 1 in 133 US citizens have celiac. That's pretty darn common, right? And if you go to other countries, you see celiac prevalence too. So there's actually plenty of factoids that I can share during our conversation, but I think that's probably the most profound thing for anybody. If you're just tuning in for this 1 minute, if you have unexplained GI symptoms, one easy test that your primary care doctor, gastroenterologist, or any subspecialty doctor, okay, even a surgeon, can order a screening blood test to look for celiac disease. And it's easy to do. And that's the best thing. Get screened, and then you could get diagnosed.
Yeah, and like a lot of health conditions, especially GI conditions, a lot of the signs and symptoms could mirror or overlap with other GI or health symptoms. And I know there's a boatload of symptoms related to celiac disease, some that we might not even think of. So what are some of the common symptoms of celiac disease that someone might experience and may not realize?
Yeah. So one thing to realize is that the contralateral of that is that some people may not have symptoms at all. Okay, so about 30% of celiac patients have no identifiable symptom. So you can be asymptomatic and still have it. That's very frustrating to know and hear. But certainly symptoms that are more overt or obvious are fatigue. Who isn't tired these days?
I know.
Right? But if you have unexplained fatigue, right, and it's not from the usual culprits, late night social media phone, right, or kids
dancing
all night long, but if you have profound fatigue or anemia, a low blood count, those are some of the most common symptoms. It's not as common to have diarrhea, but a lot of patients can have loose stools or soft stools, change in stools. More of the symptoms that are gastrointestinal might be even more vague, like bloat, discomfort. Again, if you think about it, who isn't bloated? Who isn't a little gassy every now and then? Who isn't a little distended, right? Yeah. So those are very non-specific GI symptoms. That's why if you have some type of intestinal complaint, one of the first tests that most doctors will do for you is a celiac screen, because they know just how subtle the presentation can be. You mentioned some of the other not so obvious things like neurologic complaints, commonly headaches. Okay, it's less common to develop deficiencies of vitamins from malabsorbing because of celiac that result in numbness or paresthesia, whatnot. But headaches are not uncommon manifestation. And then skin rashes. There's a skin rash called dermatitis herpetiformis. It is not herpes. So if you hear of that, it is not herpes. That's the most common misunderstanding that patients might hear when they hear it. Often a dermatologist will likely diagnose it, or a primary care physician, even before the gastroenterologist, because why would you go to a gastroenterologist for a skin rash?
Where would the skin rash appear?
It can be almost anywhere, but you can find it on your arms, on your trunk. Again, it's not a herpetic, it's not like chicken pox or anything like that. And so it's something that you would actually just go to your dermatologist for. And if we can flash a picture of it, I hope that worked.
Yeah.
A picture speaks 1,000 words.
I'm really fascinated by the fact that you said sometimes there are no symptoms. It's asymptomatic, which is really fascinating. So how would someone know whether to get screened for celiac? And is there just one test? Is there one panel? Is it genetic?
Yeah.
What do we need to know about this?
Yeah, great question. So there is a genetic component to celiac, but the diagnosis is not made off of genetics. It's actually made initially, we screen you with blood tests. So coming back, the body, the immune system views a protein called gluten, which is very ubiquitous, right? In popular culture, they talk about gluten is a part of a protein that happens to be found in wheat, barley, rye, those kind of products. And your immune system mistakes the gluten for something pathologic and starts to develop antibodies against it. And that can result in your small intestine, where you absorb nutrition. The small intestine begins to wither away. So when you eat food, it goes down your esophageal shaft, down into your stomach pouch. The stomach grinds it up and it spits it down into the small intestine. That small intestine is 23 feet long. The first part's called the duodenum, jejunum, and then the last part's called the ileum. And it often begins in the duodenum. And the duodenum is filled with sea anemone-like villi, finger-like projections. It's beautiful, actually.
Oh, we actually have beautiful footage of those little villi.
We should show those villi. That would be great. Yeah. And you could see the beautiful villi, what they look like normally. And the villi, they actually outstretch and reach out into the lumen of the intestine and absorb nutrition. But when you have celiac disease and the gluten is causing the immune system to attack the villi kind of become shorter and shorter and flat. And if they're flattened out, they can't absorb as much nutrition. And when you don't absorb nutrition, guess what? You start to get malnourished. You get nutrient deficiencies, particularly off the bat, iron. And if you can't absorb iron, you become anemic over time. That's why you always hear iron deficiency anemia being associated with celiac. And that's one of the first tests we do is a celiac test.
Now, one of the things I want to bring up, because this is so important, and I'm sure you're going to bring this up, but since we're talking about testing, the whole gluten-free thing has become so popular and trendy that there are so many people that have removed gluten from their diet, and, they may not have celiac disease. That's a whole other issue, or they could have non-celiac gluten sensitivity, and we could talk about that later. But what I want to bring up here now is the fact that you shouldn't remove gluten from your diet prior to testing for celiac disease. Is that correct?
That's 100% correct. In fact, there's a lot, that's right on. There's a lot of false negatives. People go to their doc, they want to get tested with the blood test. The blood test is called tissue transglutaminase, IgA, TTG, and it's a reaction to the gluten that we measure in your bloodstream, to keep it simple. And if that test, the TTG, is elevated, then we follow that up with a biopsy. And how do we do a biopsy? We give you some sleeping medicine, do an endoscopy, and take a little sample of tissue from the small intestine. And we look to see, are those finger-like villi atrophied? Are they blunted? Are they flat and atrophic? And if so, and then we look to see how many white blood cells are trafficking to that area to cause the inflammation. They call these intraepithelial lymphocytes. And if you meet all these criteria, then we suspect the diagnosis of celiac disease. Now, one thing you asked about earlier is what about genetics? And that's a really important question to actually address here. There are genetic markers related to the immune system. They're called HLA-DQ2 and HLA-DQ8. About 40% of people, everybody, are going to have HLA-2 positivity, but 40% of America is not have celiac disease. So we don't use this genetic test to diagnose you. Rather, we use it to actually rule out celiac. So if we think that you don't have celiac, but there's a suspicion that you might, right? Your blood test is normal, but you have gluten sensitivity. Your biopsies are normal on gluten, eating gluten. You have to do biopsies on gluten. Let's say all that's normal. And in order to rule out the diagnosis of celiac, we would do a genetic test. And if you are HLA-DQ2 negative and DQ8 negative, that would really solidify that you probably do not have celiac disease. There are some other antibodies that you'll read about, like anti-gliadin peptide and some others that are available. And there's certain use case scenarios for looking at those tests to diagnose celiac. But if you're avoiding gluten, guess what? You're going to be negative. In fact, that's the treatment for it, gluten-free diet. And so you have to eat gluten. You're absolutely right.
Yeah, I just wanted to bring that up because, I'm like one of those geeks that like to read everything. And I saw that and I was reminded to bring that up on our conversation, because what we don't want to happen is people to go and if the test is going to not be accurate, possibly because they've already taken gluten out of their diet.
Coming back, you were talking about non-celiac gluten sensitivity, and the way it's a diagnosis of exclusion. Now, I don't know about you, but Jackie, that's a very frustrating term to hear.
Oh, totally, completely.
We use that phrase, diagnosis of exclusion, with irritable bowel syndrome. We're trying to change culture around the language, because that's an old phrase that we're taking out of literature, modern day literature. So when we train new fellows and residents, we're trying to get that word out. But that phrase is still there, and so I'm using it here because it's frustrating for patients listening to this podcast to hear from their doctors still. Basically, with non-celiac gluten sensitivity, you may still have a sensitivity to gluten, but your tests are negative. And there are some explanations for that. Have you heard of? I think you have, but have you heard of fructans before?
Oh, yes, I have.
I'm preaching to the choir, obviously, but I know you guys have, immense about this. But for our listeners and viewers out there are certain carbohydrates actually all carbohydrates get fermented in our gut, our big fermentation chamber. And we've done programs here, the whole gang here, on FODMAPs. Oh, yes. And FODMAPs, fermentable oligosaccharide, disaccharide, monosaccharide, and polyols.
That's impressive, Dr. Nandi.
Say that 10 times fast.
Yes, totally. I mean, that's really impressive.
And one of those carbohydrates and naturally occurring alcohols get fermented in our gut. We get bloat, distension, and it's a useful diet for some patients with irritable bowel syndrome and managing their symptoms. Well, it turns out there's one type of carbohydrate called fructan, Fructan, not to be confused with fructose, which is a sugar. And that fructan happens to be very rich in wheat products, and it gets fermented specifically in the colon, causes a lot of bloat and distension. So this is another common thing that we look for when we interview a patient. If they don't have celiac, do they have a fructan sensitivity if they're eating a lot of wheat products?
Has the diagnosis of celiac disease evolved over the last 10 or 15 years? Or is it the same type of test? Has this changed at all? Or over the last, I would say like 20 years ago, maybe longer, these newer tests came about, but the sensitivity of the assays has become better and better. Oh, that's good.
So it is a very easy test to diagnosis, a very easy test to run to make the diagnosis.
Now, can somebody get diagnosed later on in life, or when is the diagnosis usually made? Do you know that?
What's really interesting and unfortunate about this is usually there's a delayed diagnosis. So the median age of diagnosis of celiac is about age 45.
Really?
Yeah. And so kids can get it, right? Right. And adults can get it, but about 60% of kids and about 30 to 40% of adults remain asymptomatic. When a diagnosis is made, median age is about 45. That's pretty late. And that's usually 8 to 10 years after any symptom onset, because remember, these symptoms are so vague. And so it really takes a lot, right, of uncontrolled gluten inflammation of your duodenum to finally tip the scales where you actually get symptomatic enough for a doctor to be like, you got symptoms. I went to medical school and I am going to order a celiac blood test. So it's sad, right? That's why this is why what you're doing here, thank you. Hats off to you and your team, because this is hopefully going to make people go out there and ask their doctor, bring these symptoms instead of self-dismissing them, as most people do, understandably.
Yeah, no, I think this is important because it is confusing. Even myself, I'm thinking about getting tested for celiac disease because we talked about, the rashes, and I've gotten these weird rashes recently and nothing helps them. They're gone now, but they're in weird places, like on my arms and here. I'm just bringing this out because I want the patients to know that I'm like you, I'm a patient, and I was tested a long time ago, but they didn't find, they didn't do any biopsies or anything, but they didn't say celiac disease, and they said IBS. So I'm taking your advice, and I'm probably going to go talk to my doctor because I'm curious about it as well.
Yeah, and absolutely, I don't want to make it too personal lens on you, but
no, but I mean, we help the patients.
Yeah, you're such a good person. I love you.
So are you. Good.
But you're absolutely right. So, if you're listening to this program and you've had a workup done and you're not sure, and you happen to go through your old reports and you're like, could celiac cause my symptoms? Ask your doctor first if there wasn't a biopsy done or a blood test done. Then just ask for it. It's so easy to do. Make sure you're eating gluten. There is a way, and this is actually really important, right? For anybody who has been avoiding gluten and wants to get tested, because like you said, gluten, everyone avoids gluten. You're not cool if you're not avoiding gluten, right? It's like,
I'm gluten-free.
It's a social faux pas, right? To not be gluten-free. But I love gluten. Who doesn't, right?
I'm Italian. We love pasta.
We do, right?
The gluten-free pasta doesn't cut it.
A lot of gluten alternatives we're going to talk about. But if you need to gluten load, it's a formal term, gluten challenge, gluten load. It's about 8 grams of gluten a day. It's usually about 2 slices of whole wheat bread a day. And you do that for a minimum of 6 weeks or so. And then we check the serology. Now, if the serology means the blood test, the TTG, the celiac panel, these are all the same terms, the same type of testing. And we check that 6 weeks later. And if it's normal or just a little elevated, but not quite high, you should continue the gluten load and repeat the test another 6 weeks later to see if there's like a delayed response by the immune system to show that TTG is being elevated. There's another important caveat that you made me think of, and this, everyone should listen to this. So there are different types of antibodies that your immune system makes. IgG, IgA, IgM, IgE, okay? M was as in mom. So like playing a board game, G-A-M-E.
Oh, nice.
And IgA is very specific for mucosa. Mucosa means the intestinal lining of your intestine. What does it look like? It looks pink, like the inside of our cheek. And TTG, tissue transglutaminase, IgA, that's the blood test that we check. It turns out that 2% of people are IgA deficient. So if your body doesn't make that type of immunoglobulin, that type of IgA, well, guess what? You can eat all the gluten you want. You will not mount a TTG IgA.
Oh, interesting. Oh, that's very interesting.
And so that's another reason that's rare, but and if you test enough, you'll find it. You'll find people who are IgA deficient. And so they may have a number that's just below which they should be able to make. So you can actually check an IgA level. So the way the doctor gets around that is today they do a celiac panel and it has a TTG IgA, and oftentimes they'll include an IgA level to make sure that patient can make IgA so you can test the result.
Well, it definitely sounds like it's more sophisticated in the way that you're approaching it than it was the 10 or 15 years since I remember having just a blood test and that was it. There was no biopsy or anything. So, but it sounds like the way that your thought process is, either I was not aware of the thought process of what the doctor was going through, or this is much more, we have more knowledge about all those IgAMGs that you're talking about so that we're able to kind of understand a little better, and the caveats that you just suggested to us could be in play.
Yeah.
So
yeah, I think we've come a long way. I think there's some wonderful clinicians who are part of the ACG and in our GI societies, like Dr. Kelly, who I don't know personally, but I've learned from, and that many of us learn from. And the good thing about being an academic is that the more you keep lecturing and formalizing and making these guidelines, the more you teach and pass it on, the more doctors become uniform with this knowledge. And I think I'm comfortable, to say that now in 2022, the approach to diagnosis of celiac disease is more formalized, definitely way structured, and more clinicians know how to make that diagnosis. And these pitfalls that I'm talking about, they're made sometimes, but less often than they ever were before, thanks to the great work of pioneering clinicians before me. So just to recap, we talked about symptoms. People are very often asymptomatic, but the symptoms that are there are very vague. We talked about diagnosis. While eating gluten is important to look for TTG and then confirm it with a biopsy. Remember, about 2% of people are IgA deficient. So checking an IgA level, especially if your TTG is negative, is important. And then if you're still not sure, but you think you might have gluten, or the doctor thinks with you that you may have celiac, then doing gluten challenge is extremely important. That's 2 slices of wheat bread a day. And then only to absolutely rule out celiac disease, that's the only time, in my opinion, that you should be really checking a genetic test like HLA-DQ2, which is more common than HLA-DQ8.
That makes sense. So before we get into the nutrition side of this, because this is really important, because what we want to share with patients that if you are diagnosed with celiac disease, it doesn't mean your life is over. We've talking to a lot of patient advocates who've done amazing work in the field and really guiding patients with the nutrition aspects, how to eat out in a restaurant, how to cook for a family. And there's so many products out there that are very good and gluten-free. Before we get to all that good stuff, I want to bring up non-celiac gluten sensitivity, because I know that this is a thing. There's research that shows that you can be sensitive to gluten but not have celiac disease. So can we talk a little bit about that, and also why we shouldn't avoid gluten just because we think we should, because it's trendy?
Yeah, no, I think both are really great questions. So one thing about non-celiac gluten sensitivity is that you definitely have symptoms to the gluten that you attribute. And how do you do that? You work with a dietitian. That's my advice. You work with a dietitian to do a controlled gluten exposure, and you prove it to yourself, right? Keep a diary, you have symptoms. But all your other tests are negative for celiac. The difference between celiac disease, which is gluten sensitivity immunologically, right, and celiac gluten sensitivity, is that in the former, in celiac, you develop micronutrient deficiencies. Okay, your villi do atrophy. Because they atrophy in celiac disease, you don't absorb. And so you can get iron deficiency. You can get osteopenia, osteoporosis from poor calcium vitamin D absorption and bone mineralization. And you can get the neurologic deficits. But with non-celiac gluten sensitivity, you're not going to be developing, fortunately, those same nutritional deficiencies. However, and this transitions to why we shouldn't avoid gluten if we can tolerate it. Right? Which is, it's almost cheesy, right? Food is medicine, right? But food is how we sustain ourselves. And when we restrict a food group, right, that we may not have to restrict, we not only, deprive our body of that sense of taste and flavor, we're depriving how nature packaged nutrition beautifully for absorption and digestion. And so you can develop micronutrient deficiencies and vitamin deficiencies, malnourishment, right, by avoiding food, especially to extreme measures. There's terms for avoidant restrictive food intake disorder, ARFID, right, is very underdiagnosed, very common. And for our listeners, that means you've developed a negative association or reaction or symptom with a food or foods, plural. And so you avoid it. And that's a very simplified version. But we need to prevent that from happening. So I think the one way to avoid that pitfall, or to see if you can expand your diet, again, is work with a dietitian.
Yes. And I love that you said that, because it is so important. And we did do a podcast episode on restricted eating and eating disorders in GI conditions, because patients are afraid, and we don't want patients to be afraid to eat. So working with a dietitian or even a behavioral health professional, whether it's a GI psychologist or a regular psychologist, that can work through some of those issues with you if you have fear of eating because you're in pain or you have symptoms. So don't worry, patients who are out there listening, we have resources for you. And what's bringing me to my next question about, how important is the care team, and the care team, the gastroenterologist, the registered dietitian, in managing celiac disease?
Extremely important, right? Like that is the name of the game, especially in the 21st century. Everything should be patient-centric care. And I think it's still a new concept for patients to believe or feel they're supported by a team. I think a lot of patients, and for understandably good reasons, may just feel like it's on them, right? But with celiac disease specifically, and several other chronic disease states, right, we have developed care teams and recognize we need a multidisciplinary support team. So like you said, we need a gastroenterologist, we need a primary care doctor, we need a dietitian. That's the minimum. Okay.
Yeah.
Sometimes you need a hematologist, right? Sometimes you need a rheumatologist or your primary care to help with bone health. But at a minimum, you have a couple of core people who help manage your diet and look out for you. And that's not something, and I've had patients, I don't know if you've experienced this, I've had patients feel like this is like too good to be true, or like they don't want to impose on the care team, right? But this is literally what our teams train for. They live for this, so they don't look at it as an imposition. They look at this as an opportunity to make a difference and to use what they learn for someone's benefit, your benefit. So care teams are extremely important. And I think the part of care team that makes it work is communication. And so in the 21st century, 2000 to 2020 to 20 saw the catalyst of televideo. And so now a lot of us are not only picking up the phone to call each other, but using televideo to conference and work with patients together. So care teams are extremely important. It's the thing, it's the norm, and it will be the standard now and going forth, especially for celiac.
Yeah, I think it's so fascinating that, COVID was so horrible, but also it brought to the surface so many important acceptances of technologies that weren't really utilized to their ability, to their potential, like telehealth and the video calls. And it enables, for instance, a care team to be surrounding the patient, so everyone's on the same page. There may be biopsychosocial factors that maybe someone isn't aware of, the gastroenterologist, but then the GI psych is asking or bringing to your attention, or maybe they have trouble, finding the certain food type, and that's causing stress for them. It brings everyone together. And, that's what we're trying to do with ACG and GIOnDEMAND, is to really elevate the patient experience and advance the, as that college is advancing patient care. And we've done this. We've been working with the patient care committee to bring these amazing education courses to the platform. One of them is on celiac disease, and one of the dietitians, Jessica Leibowitz, does an amazing job of, guiding a patient through what happens when they have this diagnosis, and, shopping and eating out. And she deals with the realities of what a patient would go through. So we urge patients to check that out. We have registered dietitians with specific expertise in GI and celiac disease that can help. The gastroenterologists through the ACG are amazing. So there's a lot of good resources out there. Did we miss anything important? Are there any tips you would like to give our listeners about celiac disease and what they should do if they're sort of maybe like me, having these weird rashes and maybe they're not feeling good, or maybe they think they could be? Like, what would you tell them?
I think there are three things. Two are smaller, one's big. One is, if you have any symptoms at all, you're not sure what's going on, ask your doc. You can look up Dr. Google, but ask your doctor. Consult the patient resources that the team here has grouped for you, but ask your doc, at the end of the day. And it's the easiest test to order. Two, those same blood work, if you have a diagnosis of celiac, the same serologies are used to monitor if you have any secret gluten getting in your diet. Sometimes you're really good about being gluten-free, but sometimes it's in a little soy sauce, a little this, a little that.
And cosmetics, lotions. It's in
a million different products.
There was a great abstract, I think, by the team at, was it George Washington University a few years ago, and they did this study on showing the amount of gluten in cosmetics, and they went through all the popular, consumer brands, and it was really alarming when, to see the amount of gluten in these products that you wouldn't be aware of. And someone that's ultra sensitive, they're putting that on their skin, it's absorbing into the skin and into the body, and then they're wondering why they're still not feeling well. So it's
ubiquitous. Yeah. I mean, you would never think cosmetic products, right? But there are more. There's many things that are tainted, if you will, with gluten. Now, again, gluten is not bad. If you don't have celiac, gluten is not a bad thing for you, and therefore you don't have to avoid it, especially if you don't have any symptoms to what contains gluten. But if you do have celiac disease, then gluten is something you do want to avoid. That brings me to my last point, which is, you went to the grocery store 10, 15 years ago. It was extremely difficult to find gluten-free products. If you did, they were extremely expensive. You had to go online and have things shipped to you, or learn how to make it on your own, but at cost. And it was hard. But nowadays, we have the luxury of so many people who have come before us, many of them patient advocates who learned how to make gluten-free products, how to make it taste good, how to make it healthy, how to make it nutritious still for you, right? And so when you go to the grocery store, almost every grocery store that I've been in almost has a gluten-free section. And I'm not talking one little area, I'm talking a massive area. And so I don't want to use brand names, but my local grocery store, it's amazing how many gluten-free options there are for my patients. And so that's a good thing, right? So like you said at the beginning, like some people are really scared, depressed, or sad about having to be gluten-free, right? Or have not just a diagnosis, but having to avoid all that. But it's not as daunting as it used to be. And that's great.
Yeah. And, we have great patient advocates. We had Erica Dermer, the celiac beast, on. She's a rock star, and
she's awesome.
She is so awesome. And these are the leaders that I remember years ago. They were out there forging the path, and they've even figured out how to make amazing food. Like you said, there's, substitutions. There's all sorts, instead of using regular flour, there's all sorts of flours that don't contain gluten that can substitute really well. And even in the frozen food section, there's certain things that are frozen, they're gluten-free products. And again, not everything is going to taste wonderful, but you'll learn from a lot of these patient advocates that have done reviews on the products, and they can tell you the truth. They can give you resources where you can access them. And it's pretty cool.
Yeah. It's amazing how far we've come. It really
so
is.
It's not a death sentence, and you will be okay. Patients listening and caretakers and parents, it will be okay. Would you say, Dr. Nandi?
100%. You will be okay, and you're in good hands. Yeah.
Well, thank you so much, Dr. Nandi, for being here. I really appreciate your time and dedication and continuing help, not only to serve the patients where you are, but also through this medium. We're so grateful. And don't forget to rate and review our podcast so we can continue bringing you amazing experts like Dr. Nandi. And we really hope to have you on again talking about something wonderful like this topic that we've got so much information on. So thank you so much.
Thank you for having me. I appreciate it very much.
Oh, thank you.
Thank you for listening to the Gastro Girl podcast. For more information and resources, please visit gastrogirl.com. Do you have a question for Gastro Girl? Please email podcast@gastrogirl.com. The information, opinions, and recommendations presented in the Gastro Girl podcast are not a substitute for medical advice from your healthcare professional. Please consult a licensed clinician in your state regarding all matters related to your health.